This is the immunology of HIV/AIDS by Ashley and Savannah.
What is HIV/AIDS? Acquired immunodeficiency syndrome, otherwise known as AIDS, is an ongoing chronic condition. It is caused by the human immunodeficiency virus, also called HIV. HIV damages the immune system so that the body is less able to fight infection and disease. If HIV isn't treated, it can take years before it weakens the immune system enough to become AIDS.
This next map shows the prevalence of HIV around the US. As we can see on the map, it's most prevalent in states including Texas, California, Florida, and many others, with a diagnosis around 792 up to 4,399. We can see that is very low in states around Idaho and South Dakota and in states near Maine, with diagnosis around 7 to 105. And for Nevada, we are second to highest with diagnosis around 406 and 781.
For this slide, we're looking at two graphs here. The graph on the top left is showing the prevalence of HIV in different racial and ethnic groups. Black or African Americans are a part of the 40% of the population with HIV and have the highest prevalence, closely followed by Hispanics or Latinos with 29%. Whites also follow close behind with 25% prevalence of HIV. In the bottom right corner of this slide, we have a graph looking at women of different ages with HIV. Women aged 25 to 34 have the highest numbers of HIV diagnosis at 27%.
The innate immune system of an individual is the first line of defense system, which distinguishes between self and non-self structural motifs. The first step of the HIV-1 life cycle is the attachment of GP120, which is a receptor that allows the entry of HIV into the host cell. With the host cell receptor CD4, a co-receptor, a chemokine receptor 5, or chemokine receptor 4, which are all required for successful HIV-1 binding. HIV-1 enters CD4 plus T cells, where its RNA is then converted to DNA using the host cell's energy to produce its proteins. HIV-1 infection leads to the rapid activation of plasmacytic dendritic cells to secrete inflammatory cytokines and chemokines at mucosal sites, which allows for the transmission and establishing its initial viral infection. The infection with HIV-1 causes functional impairment of natural killer T cells by a dramatic increase in inhibitory receptors and loss of activating receptors that leads to defective crosstalk with dendritic cells.
So for this next slide, we're looking at complement. Complement acts both as a beneficiary and an inhibitory agent for HIV infection. HIV can block the signaling cascade of complement proteins by complement inhibitors. HIV patients can benefit from complement because complement proteins lyse HIV particles, but HIV protein GP41 binds with the complement protein and neutralizes antibody-bounded viral particles. HIV patients can suffer from complement because HIV reduces the expression of complement receptors to impair responses of monocytes, so viruses cannot be eliminated by them. HIV GP41 shares homology with complement component C3, so it might interact with the C3 receptor to increase viral entry and viral spread of disease in host cells. This signaling cascade suppresses the inflammatory and interviral responses.
In this figure, we're looking at patients who died from HIV or AIDS. We can see that non-surviving patients had higher levels of IL-6, IL-10, and GCSF compared to the surviving group. IL-6 is a pro-inflammatory cytokine, IL-10 is an anti-inflammatory cytokine, and GCSF is a growth and maturation of neutrophils. The cytokines are possible biomarkers for prognosis in HIV and AIDS septic patients. Activation of monocytes induced by lipopolysaccharides has shown to promote a persistent inflammatory state, which can lead to elevated cytokine levels.
On this slide, we will begin talking about the adaptive immunity in HIV in regards to CD4 T cell depletion and in T regulatory cells in HIV. HIV infection is associated with progressive depletion of CD4 T lymphocytes. Persistent CD4 T cell depletion is how HIV progresses into AIDS. T regulatory cells are the body's way to downregulate the immune function, and in HIV patients, T regulatory cells express TGF-beta and interleukin-10, which are anti-inflammatory cytokines that can reduce HIV replication in CD4 T cells.
Looking more into adaptive immunity, we have found that CD4 plus T cells in the lymph node express the HIV-1 co-receptor, which is a chemokine receptor on white blood cells, CCR5. HIV has the ability to downregulate receptors on CD4 T cells, impairing its ability to work. In a hyperactive HIV-1 infection stage, high expression of apoptosis-related factors like the Fas ligand are accessory proteins. HIV has also been found to be able to escape neutralizing and death by cytotoxic T lymphocytes by the proteins on the surface of the virus being able to mutate rapidly and change shape continuously.
On this slide, we will talk about treatment used for HIV called antiretroviral therapy, also known as ART. It is a combination of medications used to treat HIV. It can reduce your levels in HIV, allowing for more CD4 T cells to be made. This allows the immune system to stay healthier and can prevent HIV from turning into something more chronic like AIDS. Antiretroviral therapy is not a cure, but many people reach undetectable levels of HIV. You may take ART as a pill every day or as a shot once every month or every 2 months.
Something we have not learned in class yet about CD4 T cells is that they have the ability to secrete perforin. These are called cytotoxic CD4 T cells. They are expanded in HIV-1 infected patients, and they also express high levels of secretion of perforin. The mechanism of cytotoxicity appeared to be primarily perforin mediated in HIV patients. CD4 plus T cells have the ability to secrete perforin and are also seen to express high levels of transcription factor TBET. In HIV-1 infected patients, up to half of HIV CD4 plus T cells were seen to be able to cause degranulation. Viral replication is necessary to maintain the presence of cytolytic CD4 T cells against HIV in the blood, and CD4 T cells prefer to use the perforin pathway, which depends on the ability of IL-2.
On this slide, we're looking at a graph that's showing the percent of memory CD4 T cells that secrete perforin in HIV negative, HIV infected, and HIV patients that are going through ART therapy. This graph shows that CD4 memory T cells lack perforin in the lymph nodes. In the peripheral blood, HIV negative patients have lower levels of CD4 memory T cells that secrete perforin than those with HIV. In the peripheral blood, HIV-infected patients have high levels of CD4 memory T cells that secrete perforin to help fight off HIV. In HIV patients going through ART therapy, CD4 memory T cells that secrete perforin are lower because there's less of a virus to fight off. The numbers of CD4 memory T cells were found in individuals with chronic infection were the highest.
In this figure, we are looking at a graph that shows the frequency of TBET high expression on memory CD4 plus T cells in HIV negative and HIV positive chronic progressors. Shown on the graph, HIV memory CD4 plus T cell response had elevated levels of TBET in HIV infected patients. CD4 plus T cells expressing high levels of TBET have cytolytic T cell effector functions. High levels of TBET are seen in HIV positive patients due to CD4 T cells that express TBET also have the ability to secrete perforin to fight against HIV infection. And those are our references, and then some more references. Thank you.